Welcome to Module 1, an Introduction to Telemedicine. The objectives for this module are to identify and characterize the three main categories of telemedicine, to classify the types of telemedicine, and to relate the HIPAA privacy and security rule to telemedicine. This module will provide the participant with a basic introduction to the terms commonly used in telemedicine. The benefits and challenges will also be discussed. The content has been designed for a clinical audience with no prior exposure to telemedicine. You may have heard the terms telehealth and telemedicine used interchangeably. While it is not entirely wrong, I want to provide a more specific definition for each term. Telemedicine is a subset of telehealth. It is the use of healthcare information exchange from one site to another through electronic communications for the health of a patient, and for the purpose of improving patient care, treatment, and services. For example, in teleradiology, telepsychiatry, teledermatology. It can also be considered the provision of remote clinical care. Telemedicine is defined by the American Telemedicine Association as the use of telecommunication and information technologies to provide clinical health care at a distance. Telehealth is an umbrella term which includes telemedicine and also includes mobile health, teleconsultations from provider to provider, remote monitoring, and the delivery of health education through video conference. Many types of technologies are used to deliver telehealth, and thus telemedicine. They include cameras, computers, and mobile medical devices, such as biosensors, to deliver electronic updates from the patient to the physician at regular intervals. Synchronous telemedicine is the category that most people think of when telemedicine is mentioned. Just like the name implies, it denotes when a patient and physician interact in real time, such as through phone or video. This may occur the same as in a regular office visit, except for the visit occurs virtually through a computer or mobile device. These interactions can be scheduled ahead of time or may occur as needed. Examples of synchronous telemedicine include a patient speaking with the on-call provider after clinic hours, a nurse giving the patient their clinical lab results, a medical provider following up with the patient after surgery, a translator service used through the phone, or a psychiatrist conducting medication checks and behavioral therapy with the patient through the convenience of the patient's home or office. There are numerous benefits for the patients who are seen through synchronous telemedicine. It resembles an in-person visit to the closest degree of the three categories. A real-time consultation may yield the best use of both parties' time and may incentivize new patients to a practice. Lastly, reimbursement tends to be easier to claim when using this method. However, there are challenges to synchronous telemedicine. They include staff training, cost associated with new technology, intimidation of new technology, integration with older technology systems, malpractice and other medical insurance coverage, and adjustments to providers' bedside manner, as well as the patient's comfort with being on camera. Now we will define asynchronous telemedicine. Asynchronous telemedicine is also referred to as store and forward. This method can still use the same communication mediums as synchronous, and even broader ones not typically found in synchronous, such as images and short video. Store and forward telemedicine is useful for radiology, known as teleradiology, and for dermatology, known as teledermatology, where detailed images and photos are needed for a particular diagnosis. The key difference between synchronous and asynchronous method is a medical provider and patient do not have to be available at the same time. This can seem convenient to both parties. However, physicians have shown to take longer to work through video and voice recordings as opposed to raw data. Inherently, asynchronous applications are not always considered telemedicine to many payers, but still may be utilized to deliver meaningful services. The benefits of asynchronous telemedicine come from a higher convenience and access to care. These afford a practice to be able to grow their patient pool while also reducing physician overhead cost. Additionally, all patient-provider interactions are recorded and usable in cases for malpractice or insurance purposes. Challenges still exist for asynchronous telemedicine. They include staff training, cost, new technology, integration with existing systems, medical and malpractice insurance coverage, and potential conflicts with existing patient interactions. Additionally, in applying asynchronous telemedicine, users must be aware of specific limitations. The completeness of diagnostic and treatment assessments can be limited by the receipt of incomplete or insufficient patient information. Also, with the nature of data relay back and forth from the patient and physician, or from physician to physician, there may be information delays. Authorization for asynchronous telemedicine varies from state to state, and physicians should check with their medical boards for the most up-to-date policies. Typical applications used on your mobile device should never be presumed to be HIPAA compliant. Always default to the highest standard when sending photos, files, or text through email or mobile applications. Make sure your administrator or IT personnel has certified your technology as HIPAA compliant, so you are not accidentally releasing patient health information to the public. The final type of telemedicine is remote monitoring. Remote monitoring is an attempt to preemptively detect and alert providers of a change in the patient's condition. With a detailed and frequent history of patients' visits and other body measurements, this method could yield a faster response and accurate triage. Remote patient monitoring includes the use of devices to track and report health conditions in an outpatient setting. Typically, remote monitoring occurs in the home of patients or at a community living center. An excellent use case for remote monitoring occurs in glucose monitoring for diabetic patients and in implantable devices for heart disease. Typical data that are tracked includes movement or steps taken, heart rate and blood pressure, hours and quality of sleep, body temperature, respiration rate, brain activity, and blood glucose. Data may be gathered through automatic or manual steps. Challenges of remote monitoring are similar to those of synchronous and asynchronous telemedicine. There may be issues with accuracy, reliability, and quality of the data. With remote monitoring, data vulnerability balances with the cost of convenience for both parties. A P2P consultation occurs between physicians or providers. The interactions can occur synchronously or asynchronously. For example, a general surgeon consulting with an oncologist using a live video feed is a provider-to-provider telemedicine encounter. Another example is an emergency physician consulting with a specialist without the patient being present. The provider-to-provider-to-consumer interaction involves consultation between physicians or providers while incorporating the patient into the interaction. An example of this type of consultation would be when a stroke neurologist examines a patient through telemedicine while the emergency room physician is physically present during the video encounter. A provider-to-patient or provider-to-consumer encounter is a face-to-face encounter between a provider and a patient through a web camera, robot, cart, or other video technology. This encounter occurs regardless of patient location or acuity level and occurs synchronously or asynchronously. It can also include continuous monitoring of patients with a visual monitoring device like a camera. An example of this type of video surveillance commonly occurs in the intensive care units or neonatal intensive care units. There has been an uptick in the telegenetics industry. This has been prompted by a progress in genomic research integrated into clinical practice. As a result, providers have begun to offer personalized medicine and genetic testing consultations. Personalization of diagnosis, therapies, and procedures may be increasingly available using applications of machine learning. Artificial intelligence applications, or AI, may speed the interpretation of data or provide predictive services indicating those who may be at increased risk for readmission or for those who may need a visit to the emergency department. With respect to telemedicine, AI could augment human tasks, provide appointment reminders, and routine condition checks based on personal monitoring. This is a special case and an area to watch as the telemedicine industry continues to emerge in various subspecialties. Terms related to geography are important, especially when discussing reimbursement, and they can be a little confusing at first. The originating site is the location of the patient at the time the service is being furnished. The distant site is the location of the physician or other licensed practitioner delivering the service. The same standard of care must be met for a telemedicine visit, so if this means the physician needs assistance at the originating site, such as to perform a physical examination, a telepresenter must be present even if the originating site is the home. A telepresenter is a trained and licensed professional, usually a nurse or certified nurse assistant, who assist in conducting a telemedicine visit. You may be wondering why we are discussing geography. It is very important when you consider the rules for reimbursement. We will dive deeper into each one of these areas in a separate module. However, you can see that the type of transaction, meaning who is paying, private or public or concierge pay, where the patient is located, and how the clinician is communicating through video plus audio or store and forward, and the role of the clinician are all very important factors in maintaining a sustainable telemedicine program. This is simply an introduction to the topic of reimbursement. This topic is complex and will be covered in greater detail in subsequent modules. Protected health information should be thought of as all digitally stored and tracked data, which is medical and could be identifiable unless otherwise scrubbed of patient identifiers. HIPAA-covered entities include healthcare clearinghouses, health plans, health insurers, and medical service providers. PHI is comprised of two parts: medical care information and identifying information. The Health Insurance Portability and Accountability Act, or HIPAA, has three major goals as it pertains to PHI: to protect health information, to standardize electronic transactions, and to enforce the act with financial penalties. Now we will discuss specific aspects of the HIPAA privacy rule. PHI must be de-identified before being released to the public or released to another organization outside of the formal business working relationship. If you are unsure of who is formally working within your organization, it is a good time to consult your administrator. The HIPAA security rule covers the following areas. First, the administrative area covers policies such as risk assessment. Second, the physical environment. This includes physically accessible devices, such as facility access controls, device and media controls. This includes your mobile devices and your cell phones that may be used to capture an image for patient transfer. And lastly, the technical. This refers to workstations. Think of password protection, privacy screens, encrypted hard drives. Basically, this is how you're going to transmit your data. In summary, in this module, we covered the three main categories of telemedicine and the various types of telemedicine, and we also discussed specific elements of the HIPAA privacy and security rule.